Either way, I'll try and get to as many as possible. And so to our speakers, a brief biography. You'll soon establish yourselves how illustrious they are. But Professor Laurence Lovat, he's a professor of gastroenterology at UCL. In normal times, as he wrote in his biography, he is the national lead for the development of AI, artificial intelligence, for the British Society of Gastroenterology. However, he's now also the UK chief investigator of an international trial of a drug to prevent COVID-19 in healthcare workers. The trial has already been awarded a multi-million-dollar grant by the COVID-19 Therapeutic Accelerator, which comprises the Gates Foundation, the Wellcome Trust, and MasterCard. Professor Peter Sasieni is the academic director of King's Clinical Trials Unit and also professor of cancer prevention at King's College London. He is a statistician and an epidemiologist. Since lockdown, he's spent 80% of his time on COVID-19 related research. And so just to kick us off, Laurence, I'm going to ask you to set the scene for us with an overarching introduction to COVID-19. As soon as I can take your mute off. Laurence.
Good evening. Can you hear me?
You can.
Jolly good. So, ladies and gentlemen, good evening. I hope you can see me. Currently I can see Stephen, so hopefully Stephen can see me.
I can.
Jolly good. So welcome from the market in Wuhan, where I'm currently. Actually, of course, I'm not really currently in the market in Wuhan. That would be a really stupid place to be. I'm actually at Victoria Falls between Zimbabwe and Zambia. And because I don't have to worry about social distancing, I can take off my face mask. But for those of you who know me, and I think quite a lot of you do, when I take off my face mask, you may just get a little bit of a surprise, because for the last 22 years, I've had a beard, but no longer. And I would just like to explain to you why I don't have a beard, because it's a little bit important. So just to start, I'm going to share my screen. I say, please God, it'll work. Just give me 1 second. It's not going to work. We are going to get this to work. Just give me 1 second. The host has disabled participant screen sharing. Would you mind enabling screen sharing? Stephen, I'm waiting for you.
Yeah, we are on it.
And I'm not going to break the suspense stage. I mean, you're just going to have to wait and see what comes. So I am going to wait. And it better be worth waiting for. And if it isn't, I apologize.
Can you try now?
Here we are. We are here. So we're going to share our screen. Can you see the gentleman with the beards?
Not as yet.
Not as yet. Oh, that's no good. It says to me, I'm sharing my screen. I'm going to try again. Share my screen.
It's part of the minhag. It's absolutely fine.
Here we go. So, can I grow a beard? Can I keep a beard during the COVID-19 crisis? Well, for those of you who sort of have a little bit of interest in this, healthcare workers have to wear these FFP3 masks when doing any form of work with a COVID-19 patient. They filtrate out aerosols, and the virus, which is only nanometers, extremely tiny, can be filtered up by these masks. And they have a very low leak rate, and they have to be specially fitted to the wearer. Now, if you have a beard, you can see there may be a little bit of an issue getting your mask to fit to your face. And indeed, 3 years ago, the Clinical Disease Center, the CDC in the USA, looked at how much leakage there is. And it turns out if you have a full beard, or indeed you have a Garibaldi or a Bandholz, there is anything up to 1,000 times more leakage than if you have a Zappa moustache. And so the obvious thing to do was to get rid of the beard and to replace it with a Zappa moustache. Unfortunately, my wife didn't like that, so I had to get rid of that as well. So is there any evidence around the use of face masks? So you know there's been a call in the last week for people to make their own face masks. This is some work that was published in the Journal of American Medical Association about 3 years ago. a cotton handkerchief, or essentially what people are making now, these sort of cloth masks, will reduce particles by about almost 30%. So what's the point of wearing one? Well, it's not necessarily going to protect the wearer, but it's very much going to protect the people that wearer comes in contact with. Whereas if you wear a surgical mask, even a basic surgical mask, it seems actually does partially protect the wearer. Having said that, it's only 80% protection, and the respirators that we use when we're with COVID patients are 99%. So that's why we tend to use those, but in fact, even these surgical masks seem to have some value. On the 11th of March, the World Health Organization announced that there was a pandemic. And since then, we have been working through the problems of the pandemic. What we know already is that the vast majority of people, oops, you're looking at my WhatsApp group, never mind. The vast majority of people get the disease very mildly, but about 15% get severe disease. That means they have shortness of breath, admitted to hospital, and 5% become critically ill. And that, of course, you all know means going on a ventilator and sadly some people dying. The particular populations who have become very clear are susceptible. Of course, the elderly, those people who have underlying medical conditions, but also healthcare workers. And you've heard a lot in the last week about Black, Asian, and minority ethnic people, particularly amongst healthcare workers, being specifically at risk. So the healthcare worker issue is actually rather interesting. In China, in the original work, it became clear that it was about 5% of those with COVID-19 were healthcare workers. And then in Italy, it became 9%. And in the UK and other countries, it's around 10%, seem to have some sort of connection with healthcare work. And of course, there is no proven prevention or treatment for this disease. So it's really a bit of a problem if you're a doctor or a nurse or a porter or a physiotherapist or indeed a carer in a care home, because what do you do to protect yourself? Well, of course, we're all waiting for the vaccine, but we don't yet know how effective that's going to be. Let me just talk for a minute about the actual virus itself and just explain to you a little bit how it works. You're going to see my WhatsApp again, I think. Sorry, here we go. So here is the virus. Now, a virus is a bit dubious as to whether a virus is actually a living thing at all, but essentially the virus has a coat, a membrane, which these wonderful things called spike glycoproteins. I think great, spike glycoproteins around the edge. And in the middle, it has this thing called RNA. Now, you've heard of DNA. That's, of course, what codes for life. And in humans and in other animals, the DNA is then translated into RNA, which is what's sitting in this virus. And the RNA then encodes for the proteins, and that's made. The virus can't do that. All it has is the RNA surrounded by this spike glycoprotein in the envelope. And so what actually happens when the virus gets into the body, the virus actually attaches itself to receptors which are sitting on cell walls, and it gets endocytosed, it gets sucked into the cell, and this is an active mechanism. And then once it gets into the cell, the membrane, the coat, is taken off. The RNA is then free to use the cell's apparatus to replicate itself, to make far more RNA and, of course, proteins, to make a whole load more viruses, which then get shoved out at the other side of the cell if it hasn't killed the cell in the process, and then to infect the next cell along, or many cells, because in fact there are many virus particles will be produced. But at the same time, it activates the body's responses because it's seeing a foreign molecule there. So let's just talk briefly about how the disease normally goes. One gets exposed to the coronavirus, infected on day 0. Between 7 and 14 days later, the person will get a fever and a cough, and then within about a week, it tends to resolve. And that's what happens to the majority of people, and indeed, many people won't even know they've had it. They don't even get the fever or the cough. Because they may get other symptoms, for example, a loss of taste and smell, or no symptoms at all. So that's sort of a fairly standard thing that happens to most people, and that's not too worrying. When it becomes a bit more worrying is when it's at 7 days after the fever and the cough, it doesn't resolve, but instead the body's immune system goes into overdrive. And this is called a cytokine storm. The cytokines are the molecules that drive the immune system, and it just goes completely mad. And then if that happens, even in those cases, so people who feel really sick at this point, they still, most of them will resolve. However, as you all know, a small number end up in hospital requiring breathing support, whether that's CPAP with a mask or more seriously with a ventilator. And you're probably also aware that some people can stay on ventilators for weeks and weeks and weeks, and not surprisingly, at the end of that, they don't just get better, they have to have extended rehabilitation. Unfortunately, some people who go onto the breathing support also develop other complications, multi-organ failure, often due to microthrombi, little blood clots. And again, they can get better, but sadly, we already know that people who are having this treatment, who are on ventilators, about 50% in this country are dying, and in other countries that death rate is almost 100% once they have to be ventilated. So if you think about drug trials, and we're going to talk a fair amount about these over the next little while, we think about prophylaxis, which means when people are exposed, stopping them getting the disease. Mitigation, when people have got the disease, stopping them getting serious disease or severe disease, and when they've got severe disease, trying to get them better quicker. And that's where we're going to go, looking at these various areas. And with that, I'm going to hand over to Peter Sasieni.
Thank you. Can you see me? Hi. Thank you very much, Professor Lovat. I'm an epidemiologist. Until recently, I only worked on chronic diseases, cancer. But ironically, the last time I went to a meeting abroad was to the World Health Organization at the beginning of March. It was just a couple of days before they declared COVID-19 to be a pandemic. I want to talk to you a little bit about the R number and testing, because I think that could possibly be a route to ending the lockdown and getting life back to normal again. You will all have heard about R on the news and in the papers, but probably had never heard about it before. It is the average number of people infected by one infected individual. So if you start with one person, if R is 5, then they give the disease to 5 other people. And then because that works in a chain, and if it takes 5 days on average, so R for COVID is thought to be around 3, and that would mean that one person could spread the disease to 729 people over a month. So it's really important. If R is greater than 1, the epidemic grows exponentially. If it's equal to 1, it just chugs along steadily and doesn't become a real epidemic. And if you can get R below 1, then the disease will decrease and hopefully disappear. So the role of epidemic control, the goal is to get R below 1. With measles, for instance, we have a vaccine. The R is about 5. If you can vaccinate 80% of the population, you would get rid of 80% of that R and take it down to 1. And that's what's called herd immunity. So the vaccine is not only great for the individuals who are vaccinated, it prevents them getting disease, but actually, since there are some people who, for whatever reasons, medically are unable to be vaccinated, if you can get over that proportion of the population vaccinated, you can get R to become below 1, and you can prevent an epidemic of the disease. And that's what we've been done with measles. But unfortunately, there is as yet no vaccine for COVID-19. There's one which has just started trials. I think it was meant to start today, but there's some little issue that it will be starting sometime this week. But it's going to be a very long time before the majority of people in this country could get the vaccine, and even more so before it's available for the majority of people in the world. It's going to take a long time to prove that the vaccine works and then to produce enough of it. So the second approach that we've used is lockdown. If in normal circumstances, as you mix and socialize and see friends and family, you might see 12 people whilst you've been infected and before you have symptoms and decide you better stay home. And of those 12 people, you might give it to 3 of them. So with lockdown, instead of mixing with 12 people, you might only mix with 2 or 3, and hopefully then you give it to fewer than 1. And that's what's happened in this country. R was somewhere around 2.5 or 3 beforehand, and it's estimated to be around 0.5 to 0.8 at the moment. So lockdown is one way of doing it, but it's dire. It's destroyed the economy, it's given people mental health problems, and it's caused a lot of problems. For instance, with cancer, people are not getting diagnosed because they're frightened of going to the hospitals and they can't get the treatments that they need. So the other traditional approach, which is used for a lot of epidemics and to prevent epidemics, is what they call test, trace, and isolate. And a lot of people now have added support as well. So I wanted to share my slide. I don't know if I can do this or whether it's going to prevent me.
You should be able to, Peter.
Yeah. Has that worked?
Yes.
Yes. Okay. I don't know quite what's going on, but so the idea is that you test everyone with symptoms, and anyone who has the virus, you then go and trace everyone that they've been in close contact with over the last few days, and you test them. And one of the things that makes it so difficult for COVID-19 is that rather than having to think about the last 24 or 48 hours, you probably need to think about the last 5 days. And so that could be a lot of people, particularly if you've been on the tube or the buses. And then you want to test everyone who they've been in contact with. So all the people you've traced, you test. And if any of them test positive, you immediately isolate them and also continue. So you trace their contacts. So it's this sort of chain reaction that you try and get it. And by testing people who haven't yet got symptoms and isolating them, you hope to break the spread of the epidemic. And that works very well for viruses that produce symptoms pretty quickly, but it's much, much harder for COVID-19 because of the long time between being infection and becoming ill. But in addition, if you're going to isolate people, you need to provide support for them. And so that's one of the key issues. And the Scots are trying to do this. And then I want to do a variation of this where we would split the population up. We want to split R into the amount of the transmission that is happening within the household and the amount that is happening between households. And the reason is because if you tested people, and as soon as anyone in the household tests positive, you isolate the whole household, in that way you can bring down R more, because from the point of view of the epidemic, it doesn't matter if you're only spreading it to people in the household, so long as they don't go out and spread it to others. And so the only thing that now matters is how much is being spread from household to household. And it's estimated that about 1/3 of the spread at the moment is within households. So just prior to the lockdown. So just dealing with this approach would immediately get rid of 1/3 of the R, and it then becomes much easier to do things. So a lot of people think there should be far more testing going on, and so myself and some other epidemiologists think that actually it might be a great idea if we could test everybody in the country once a week. Now that sounds completely impossible. We can't even cope with 10,000 tests a day in this country, and I'd be talking about with 100,000 tests a day, and I'd be talking about 100 times that, about 10 million tests a day. Nevertheless, I think the cost of lockdown and what it's done to the economy is such that this is worth testing out. And so what we're suggesting is that you'd pick a medium-sized city or a smaller city, maybe Newcastle, maybe something somewhat smaller, and you would test to see if you could test everyone in that city once a week. You wouldn't have to get 100% of the people. You'd need to get the results back quickly. If anyone in the household tests positive, they need to stay home. The whole household needs to stay home. But otherwise, you'd let people out. They could start going to cinema, to restaurants, to go to shul midweek, you'd probably need some sort of electronic certificate to prove that you have been tested and you're negative. If you don't want to be testing, that's fine. But if you want to go back into society and enjoy going to football matches or on the tube, you're going to have to demonstrate that actually it's safe for you to do so.
Peter, sorry to interrupt, just for a point of information for the people on the call. When we talk about testing, is there currently a system in place where people can get immediate results, or results immediate enough that they could do the test, be processed, and then make the decision to leave or remain isolated?
Okay, yeah, so there are two sort of, this test is the viral testing rather than the antibody testing. It seems that you need a good sample to have a reliable test, and that means probably someone else has to take it for you, because you need to pass a swab fairly high up the nose, and it's not that comfortable, so most people wouldn't do it. There is some suggestion you can take a swab both from the back of your throat and from your nose, and that might be good enough. There is a machine that will analyze that sample in 15 minutes. So there is no real problem. You've got to get the sample to a lab. The lab have to sort out how they're doing things. You may want to say that because the most samples test negative, we'll put several together and only test them as a batch, because if you put 15 together and they're all negative, and the sample comes back negative, you know that all 15 are negative, and if not, you test them. So there are things you could do, but if you set it up with a laboratory, there is absolutely no reason why you can't get the result back quite quickly. I know there's one hospital that is testing staff in the morning and giving them the results before they go home at the end of their shift. On the other hand, there's also talk about samples being sent off to America because they didn't have capacity here, and it's taking 10 days to get the results. So, but I think, if you're doing this, you want to encourage people to take part. So you'd say that if you have to be locked down because someone in your household has tested positive, well, if that's not you and you're an elderly person, maybe you could go to a nice hotel, which the government would pay for. And if you're stuck at home, you could get free meals delivered from the restaurant of your choice. And you might even pay people £50 a day. I mean, we're paying furloughing, which is far more. So this would allow people to get out and about. It would cost money. You'll need people to collect the samples. You need people to test them in the labs. But in principle, it's something that I think is worth doing, because I don't really see how life will get back to normal otherwise until we've got a vaccine, and that could be 2 or 3 years away. So I think am I handing over to Laurence, or am I talking a bit more?
I think you were going to talk about clinical research.
A little bit more clinical research. Yeah. So yeah, and I wanted to explain what research is and why it's important. And I'm sharing my screen again. I know Laurence had a similar slide he was going to use. And many of you will have heard President Trump saying back at the early in mid-March that there was this amazing drug. And the history is that on the 13th of March, there was a paper that was published on the internet. It wasn't reviewed by anyone. Just some scientists were saying that they think that hydroxychloroquine may work against COVID-19, and they'd done a few little experiments. A week later, and I don't know exactly how he heard about it, but President Trump tweeted, and I'm going to read this tweet: hydroxychloroquine and erythromycin taken together have a real chance to be one of the biggest game changers in the history of medicine. And as you can imagine, that had enormous impact around the world. Some of you may have seen this doctor on the left. He's a Hasidic Jew, a Russian name, Vladimir Zelenko or something. And he put a video on the internet saying that he was treating all his patients at home with hydroxychloroquine and zinc, and it was wonderful, and everyone was doing great. I then got 2 phone calls from within the community, one from a doctor who wanted to do some sort of clinical trial in Hendon and Golders Green, in which anyone with COVID-19 could get hydroxychloroquine. and another from a member of the community who wanted to know how he could buy hydroxychloroquine for himself, just in case he got it. A week or so after that, there was a Swedish study looking at this drug, which was stopped because there were serious side effects. A week and a bit after that, there was another one in Brazil. Meanwhile, President Trump ordered 29 million doses of hydroxychloroquine. The drug is used for treating people with some certain other conditions, and they couldn't get the drug that they need for their everyday life. And then on the 21st of April, exactly a month after President Trump's tweet, the US study that was looking at it decided that it had no effect. And a few days later, the FDA warned against its use. It appeared to have no beneficial effect in treating people with severe COVID-19, and there were some cases of people dying from side effects of the combined drug hydroxychloroquine and azithromycin. So there is a danger of not doing research, and the whole point of doing clinical research is in order to demonstrate that what the hoped for effects of the drug you have are real, and there are no serious side effects that change the benefit to harm ratio. So I'm going to stop sharing and try to continue. I don't know why I can't continue. So the only way to really tell whether a drug is working is to do a randomized controlled trial. And the main aspects of these are that there's randomization, which means that you ensure that the groups, the people who get the drug and the people who don't get the drug, are comparable. There's blinding, generally, which means that you're trying to eliminate a subjective bias, that when you're trying to decide, has it worked, you don't know whether the person got the drug or not. And then, because things are blinded, you need to have what in America they call a data safety and monitoring board. It's an independent group to review the data from the study. This is in case either there are some side effects that you didn't expect, or hopefully it turns out to be a wonder drug and you need to stop the trial much earlier because it's saving everyone's lives. And so I'm on the data monitoring committee for a big American study, the one that's funded by the US government. It's called Adaptive COVID-19 Treatment Trial ACT, and it's going to look at a series of drugs, one after the other. And they're looking at treating hospitalized patients with fairly severe COVID-19, and they're trying to improve the time to recovery. And it's studies going on in about 100 hospitals worldwide, and the first study recruited over 1,000 patients. It was studying a drug called remdesivir, and it was comparing remdesivir to a placebo, so something that looked the same but was not an active drug. Remdesivir was invented for treatment of hepatitis C. It didn't really work for hepatitis C. It was then used for Ebola with anecdotally quite good results. And in a laboratory setting, it's been shown to have effects against coronaviruses in the past, so SARS, and in particular about COVID-19. So that was the drug that was being used. And what normally happens on a data safety board is that we meet about 3 times a year. We get together, we have a chat about the data, and everyone says, well done, and off we go. What happened in this trial was rather different. We were meeting at one point once a week. We had people who were 8 hours behind us on the west coast of America, and someone who was 7 hours ahead in Hong Kong. So getting the timing right for these meetings was quite difficult. And we couldn't tell whether the drugs were having serious life-threatening side effects or whether they were preventing the worsening of COVID-19. So we had been told that this is arm A and this is arm B, but we didn't know which of A and B was which. And normally that's fine, but here, because we didn't know if someone got renal failure, is that because their COVID-19 has just progressed terribly, or is it because of side effect of the drug? So we asked to see which arm was which rather earlier, and we did that. And then on the 27th of April, which I think is when Professor Lovat was talking to Ner Yisrael, I was meeting with the board, and that was the first time that we were discussing the results of the trial. We decided that the results were so good that it would be unethical in the next trial, which they wanted to start the next day, to only give some patients a placebo. So there was going to be another drug that was looked at, but we felt that everyone had to get some drug. Either they should get remdesivir or they should get the new treatment. And in fact, the trial, they decided that they wanted to give everyone remdesivir in the new trial, and then on top of that, they would either be given the new drug or a new placebo. And so that's what happened. And 2 days later, Dr. Fauci, who's the lead in the National Institutes of Allergy and Infectious Diseases in America, at a press conference with President Trump, said that this drug worked, and a few days later the FDA approved of it, and it's still currently the only drug that has been shown to work against COVID-19. Thank you.
Thanks for that, Peter. I think I mean, it's unbelievable the amount of terminology that we didn't know as a race before. Now everyone knows remdesivir and epidemiology, and you know, Scrabble will never be the same again after this. But I'm going to throw back over now to Laurence, who's going to tell us more specifically on drugs. Laurence, I'll unmute you. I know. The power is unbelievable. I might never give this back. 1 second. You're free to speak.
Okay, I'm unmuted, and I've also migrated. As you can see, I'm now in South Africa. I like sort of popping around the world. Just to remind you, ladies and gentlemen, we talked about sort of 3 types of drugs, 3 areas of disease. We've got prophylaxis, try and prevent it, mitigation, and then sort of cure and support. I would like just to, hang on, what am I doing? I don't know what I'm doing. I don't think you saw that. I just want to talk briefly about the different types of treatments. You've heard about hydroxychloroquine failing in people with advanced disease. But actually, that's not necessarily a great surprise, because the issue is that people who've got advanced disease have got a very, very powerful immune reaction. And hydroxychloroquine and chloroquine are known, amongst other things, to prevent virus from entering into cells. And once the virus has entered the cells and left the cells, and you've got the immune response, they're not necessarily going to be so effective. So you've got to think about the different types of drugs for the different stages of disease. So antivirals to prevent the virus from replicating, drugs to prevent virus from entering into the cells, and then the anti-inflammatory drugs, which stop people from mounting this nasty immune response. And then, of course, things like ventilators to help them once they can't breathe and once the effects of the overactive immune system has got going. So we've, Peter's talked to you about this platform trial called the ACT trial, which is an American one. It turns out that everybody's got on the bandwagon. The World Health Organization launched the Solidarity trial. Again, it's looking at different drugs. Remdesivir is one, lopinavir, ritonavir, these are HIV drugs, which is the second arm. Interferon beta, which is an anti-immune system drug, that's to try and damp down the immune system, and then the chloroquine, hydroxychloroquine. That's the World Health Organization. And then, just to make their life even more miserable, the Brits, because we do everything ourselves, have got the randomized evaluation of COVID-19 therapy, the recovery trial. And that trial has been going in, it's been recruiting extremely well in England. And as of last week, it had recruited over 10,000 people who all had severe COVID-19, looking at various drugs, including lopinavir, ritonavir, and steroids and various other things. And one of the real problems, it turns out, that if you have lots of different trials, and guess what, lockdown works and less people are now coming into hospital, you don't necessarily get enough people to be able to work out the answers for your drugs, because you need very large numbers of people to be able to establish whether drugs work. And I heard in a meeting I was at last week that, in fact, the recovery trial needs a minimum of 12,000 people to be able to get results, but it's only got just over 10,000. And of course, people are not coming into hospital nearly as fast as they were. So I'll just tell you about a couple of other things. I sit on this research meeting at University College Hospital, and every week we review all the studies that are going on. And not only do we have access to the recovery trial, but also we have a whole load of new and novel ideas that are being tested out in a research hospital like ours. So, for example, there's a drug called tocilizumab. It's an immune modulating drug. It's used already for rheumatoid arthritis, and it works to reduce the activity of one of these cytokines in the cytokine storm called interleukin-6. And interleukin-6 is very, very important in a whole series of diseases like celiac disease, diabetes, Graves' disease, thyroid overactivity, Crohn's disease, multiple sclerosis, psoriasis, rheumatoid arthritis, multiple myeloma, prostate cancer. Interleukin-6 is terribly important. And so it turns out there are drugs to reduce the activity of interleukin-6, this pro-inflammatory cytokine. And this drug, tocilizumab, is being used at the moment in trials in patients in hospital. But these are much smaller trials because it's a new drug. Another idea, plasma exchange. So the cytokines, this cytokine storm, they are being sent round the body in the blood. So if you're able to suck them out of the blood, perhaps you will get some response. And indeed, small trials have shown that this actually works. But this is really very much the beginning stage, and it will take quite a while to ramp these things up to see where they work in bigger trials. And I'm going to hand back over briefly to Peter, and then I'm going to come back in a couple of minutes. So Peter, over to you.
And just to interlude for a second, thank you, Laurence. Just to keep one eye on the time, gentlemen, there's lots to talk about, but there are plenty of people who've got questions. We have an enormous amount of amazing stuff to go through, but if I can ask you to keep it as rapid fire as you can, we'll get to questions, which I know will be appreciated by everyone.
Peter's on mute.
Peter, let me unmute you. Sorry,
Okay,
Peter.
Don't worry. So as Laurence was saying, it's very natural that the initial emphasis should be on treating people who are otherwise perhaps dying from the disease. But both he and I are particularly interested in these prophylaxis trials. For me, that becomes, because that's what I do normally. I'm a professor of cancer prevention, and for many years I've been doing studies of drugs to reduce the risk of people getting cancer. And I'm not thinking about vaccine trials, although I'm hopeful to actually to be studying a vaccine in people with HIV, because not only are they more susceptible, and that's important for them in this country, but in terms of a global epidemic, in Africa, a very high proportion of the population are HIV positive, and if the vaccine doesn't work in people who are HIV positive, it won't work in controlling the epidemic there. But we're talking about things which will reduce the risk of getting infected. It won't eliminate it to zero. And you need to think about, if you're doing those studies, you need to think, who should you target? And it's obvious you want to put people who are at high risk of getting infected, and both Professor Lovat and I thought NHS staff initially, where I think we're both now thinking about care home staff as well. The latest data showing that the death rate amongst care home staff is at least double that of hospital staff. And also people perhaps who are sharing a house with someone who's just got symptoms or just tested positive. So those are the people who are at highest risk, and those are the people you'd want to target. And then the second thing that you need to think about is, what sort of drugs do you want to use? And we want a drug that we know quite a lot about. And so we talk about repurposing drugs. And both Laurence and I have talked about drugs that have been used for other things in the past. If that's the case, you know they're fairly safe. There should be no life-threatening side effects, or they should be extremely rare. And any common side effects have got to be easily manageable and temporary, so that they, you may get them for a week or two, but it passes. And then you want the drug to work against other infections. You're not going to think it's going to work against SARS-CoV-2, the virus that causes COVID-19, unless you know it works something else. And then within a lab, you'd like to know that actually it also binds and does something with this particular virus, not necessarily in a clinical setting, but in a laboratory setting. So that's what you're looking for the drugs. And when you're trying to do the first wave, then you want to recruit people as quickly as possible. You want to treat them straight away. And you need to think about how do you do this whilst there's an epidemic going on. So you want to avoid hospital visits as much as possible in order to maintain social distancing, but also because all the research nurses, all the people that I normally work with, the nurses to do research, they've all been seconded back to the wards. They're treating patients, or they were a few weeks ago. So we couldn't use them for doing research. So we wanted to use an app to do most of the managing of the trial, and we were getting people to collect samples themselves rather than having a nurse collect samples. And we wanted to do a trial where you would get results within a couple of months. And so if the drug worked, you could then be using it before the second wave. Unfortunately, nowhere in the world was there such a trial. So we're now at a problem which Laurence talked about. We could have the wonderful situation that nobody gets the virus anymore. That would be wonderful for the world, but it wouldn't be very good for research, because if nobody gets it in the control arm, we can't show that the drug works or not, because no one's getting it. And so I think you need to do a trial where you're going to recruit people now, but you somehow trigger when they start taking the drug, once the second wave begins or once they're exposed to it. And so with those general principles, I'm handing back over to Laurence to talk about the trial that he's been working with.
Excellent handover there.
So I've moved, I'm now in Canada. Anybody been to the Rockies? It's a great place to go. I recommend it when we can start traveling again. But actually, Peter has very nicely introduced you to the trial that I'm leading here in the UK. It's called the Crown Coronation Trial. And this is chloroquine repurposing for healthcare workers. And I'll just show you a quick link to that, if I can. It was a great idea, but it didn't work. There you go. The Crown Coronation Trial, chloroquine repurposing. So this is reusing chloroquine, but you've just heard from Peter how terrible this drug is, how awful it was, how it didn't work, and how dangerous it is. So it turns out that it doesn't work for people with advanced disease. But remember what I told you before, we're looking at prophylaxis. We're looking trying to prevent viral entry. And furthermore, when you're doing a prophylaxis to prevent disease, you use far lower doses of the drug than you do for treatment. And you don't use it with azithromycin. And it turns out that combination is what's dangerous, not the chloroquine by itself. Anyway, be that as it may. So the chloroquine has actually been in use for almost 80 years. And in fact, apart from paracetamol, it is the most used drug in the entire world. We know an awful lot about it. So I just want to show you how chloroquine actually works. So if you look at this screen here, you can see that, oops, no, sorry, that's the next one. You can see the viral entry into the cells is blocked by chloroquine. Chloroquine also prevents the RNA replication of the virus, and it also has an anti-inflammatory effect. Indeed, hydroxychloroquine is used for rheumatoid arthritis, but we're most interested in this early phase here, which seems to be potentially important. And the fact is, ladies and gentlemen, we just don't know whether it works. So here's another interesting fact. I quite like this. This is the 3rd of March. Okay, who can remember the 3rd of March? But at that point, China was the big bad guy. Iran was looking pretty nasty, and Italy was sort of starting to pop up. But you know, the UK had what, 100 cases or something, and there was absolutely nothing going on in Africa. And this, I'm sorry, they're not the same colours. You can't find the same graphs month after month. This is April, 8th of April, and now the numbers are going up to the tens of thousands. And the UK is, you know, looking pretty bad. America's starting to look nasty. Africa's still looking pretty clean, with the exception of South Africa. And this is the latest map. And now notice, South Africa's got 14,000 cases. Ghana's got 5,500. That's Cameroon with 3,500. Senegal with 2,500. And I'll just point out here, actually, in South America, Peru has got 88,000, Brazil with a 250,000. And these countries are what we call low-income countries. You know, they don't have the resources we have. And so the Crown Coronation trial is looking at prophylaxis, not just in the UK and Ireland and America and Canada, but actually in a whole load of countries in Africa and also in Peru, where they have low levels of resource. Because if, God forbid, somebody gets sick, a healthcare worker gets sick in these countries, is what we call an ochenwee. So there are three questions we're trying to answer with this trial. First, does chloroquine prevent people getting symptomatic COVID-19? Secondly, whether it mitigates the severity. And thirdly, we're actually doing multiple doses to see what the lowest dose is that will prevent people from getting the sick. And by focusing on preventing and mitigating disease amongst those that are at high risk, the healthcare workers, you're not only making them not get sick, but actually you are preventing the problems of the complete disruption of healthcare within very vulnerable communities. And if prevention works, we can maintain not only continuity of clinical care, but of course, we can create a better environment which makes people feel more comfortable. Because actually, if you remember 8 weeks ago, the anxiety we all had about COVID-19, if all your doctors and nurses are all getting sick, I can assure you your anxiety level is going to get a hell of a lot higher. And that's all I'm going to say about this trial. And that's actually me done. So I'll hand back over to Stephen.
Thank you so much. We're going to move to some Q&A with the time we have left. Again, if you would like to ask a question, please do try and raise your hand or message me. I think we've enabled messaging now. First question we've had, and actually it coincides with something that Peter was going to talk about. Peter, can I get an answer from you around the benefits of vitamin D with regards to tackling coronavirus?
Sure. So there is very little evidence about vitamin D and coronavirus. Vitamin D is now recommended for everyone by the NHS. That's partly because it's always recommended for people who are, sorry, my kids are doing something. Oh, my video's off. Sorry.
We can hear you. We can hear.
You can hear me. Yeah, I know my
now
video. Sorry. So, my kids came in to turn my video on. It's always recommended for people who have low levels of vitamin D. Vitamin D is mostly from sunlight. And so they're saying because of the lockdown, a lot of people will not have been getting enough sunlight. So they're saying everyone should take it. There is evidence before from randomized trials that giving people vitamin D reduces the risk of chest infections by about 20% in most people, in most of the population, by as much as 70% in people with really low levels. And now there's some data from India showing that amongst the people in hospital with COVID-19, over 90% of those who had very low levels had very severe illness, compared to 60% of the people with good levels of vitamin D. So it seems to make sense to take it. I'm taking it. I've persuaded the Maudsley Hospital, which is a psychiatric hospital, to give it to all their inpatients because psychiatric patients generally have very low levels of vitamin D. And I'm not a doctor, so if you want to know whether you should take it or not, you better ask Laurence.
Thank you. We shall come to that. We've got a question from Stephen Wilson. I'm going to unmute you, Stephen. I'm going to try and unmute you.
Very good. I think we're there. Am I unmuted?
You are.
Great. Hello, Stephen. Hello, Laurence, and hello, Peter. Good to see you all. Peter, it's a question about the calculation of R. Just interested in how R is calculated, but I'm interested in particular if every time that there's a change in the lockdown and the government says they're going to leave 2 to 3 weeks to see what the effect is it possible within that time frame to calculate R again, having taken into account what the actual effect of R is of the lockdown change?
So I'm not an expert on calculating R. If you were doing enough testing, you could calculate R much more easily. Otherwise, they're calculating R based on the numbers of people going into hospital. And so from the rate at which the virus increases or decreases, you can calculate R. It will be a little bit behind, but probably only about 5 days behind. If we were doing lots and lots of testing, and testing has started of sort of random people in different parts of the country, then it would be rather easier to calculate R. But probably only if you're doing the sort of the contact tracing approach. So it's not very well known, and they only know that it's somewhere between about 0.5 and 0.9 just prior to them sort of easing off the lockdown. And that's one of the difficulties that the government and the advisors have. We don't really know exactly how big an impact changing things will have on R. We don't know exactly what R is.
Thank you. We have two questions that I'm going to ask together, and I'll throw to Laurence for the first, and then Peter can jump in on the second, I guess, or you can count them between you. And then we also have, we'll go to Lara Stoya after that. Forgive me if I've mispronounced your name, Lara. So first from Dan Scherf, do you think there should be any change in general advice or restrictions for people who've had test-proven COVID and have recovered? And second question from Julian Pollard, around vaccine trials in Israel. We've seen news of breakthroughs potentially in Israel on vaccine trials, I think for antibody tests. Do either of you want to take either of those? To unmute, I believe.
Yeah, Peter, you're sharing your screen. You might want to sort of unshare. Can you hear me now?
We can.
Yeah. So as far as people who've had positive tests, having a certificate, the interesting thing is that the Roche test has now come along, which has 100% specificity. And what that means is if it says you're positive, then you've had the disease. So that's a big leap forward, because even if a test is only 98% specific, it means that 2 out of every 100 people would have tested positive didn't have the disease. At least this one is 100% accurate in that respect. The real problem is we don't know how long you're immune for. Everybody must be immune for a while, but actually we're not sure how long that immunity lasts. And so the whole question about if you've had a positive test, how valuable that will be and how sensible it is for you to go and mix with other people, I think is a moot point. And indeed, it's something one could test. I'm not sure I'd wish to, but it's certainly one could test. Just to move on, and Peter may have another view on it, but let me just answer the vaccine question. There are an unprecedented number of vaccine types that are being developed. In preclinical testing, there are 80 different vaccine studies going on using 1, 2, 3, 4, 5, 6, 7, I think at least 15 different approaches to developing vaccines. And this has never happened in humankind. And once you've decided that something appears to work in a test tube, you then have to try it in animals, and then in small numbers of people, large numbers, and then very large numbers of people. I don't quite know what's going on in Israel. Israel is always very good at coming up with sort of the novel ideas. Whether they will get all the way through, I think is also a difficult thing to judge at this point. No one really knows.
Just with an eye on the time, I'm going to unmute Lara. Lara, your question.
Hi, it's actually for my husband, who's Alan Stoya.
Sorry, yes, Stephen, I actually hijacked Laura's...
oh, sorry, carry on.
That's okay. Just a really quick, by the way, Laurence and Peter, really great talk, very much enjoyed it. But I just wanted to target a question of Laurence here. As one of those healthcare workers that you would like to try and recruit for your study in prevention or prophylaxis using hydroxychloroquine, how are you going to convince me that a drug would be in my best interest when I may well be in one of those 85% of people who is going to have this very mildly, and why would I want to expose myself, albeit small, to the risk of the drug?
So it's a very interesting question, of course, because about 6 weeks ago, when we started mooting this, every single person we spoke to said, I want to be in this trial, right? Anything I can do to stop myself getting COVID-19. And then, of course, you started hearing some of the risks that are being touted, which actually have been overstated. And I've got all the evidence, and I can, if you want, and I'll sit with it afterwards and show you all the evidence. But then people start going, oh, I'm not sure. And what's fascinating, however, is that the people who are in the high-risk places, so for example, at the moment I'm talking to the National Institute of Health Research, lead for geriatrics and care of the elderly, and the care home workers are desperate to get into these trials because they are at the moment right at the front line. So people who are right at the front line are prepared to take a little risk to prevent a big risk. And I think that's probably, it sells itself. If it doesn't sell itself, it's not worth doing, I don't.
Thank you.
Peter, you're happy with that, or did you want to ask? Do you want to say something else?
No, I think that's a very reasonable question. I guess when the virus first struck, a lot of people were trying to obtain hydroxychloroquine because of Donald Trump, and I think a lot of harm was caused because of that. But clearly, we now need the science to tell us whether it's helpful. But I wondered whether you had any data when this first emerged. The Indian Medical Society put all of their doctors on prophylactic hydroxychloroquine. I'm not sure whether it was ever properly studied and whether there was any outcome. But it would be
it's a disaster. It's a disaster because Bangladesh have done it as well. And they're putting large numbers of people onto a drug. They don't know the efficacy. They don't know the risks. I mean, we know the risks are pretty low, but when you're doing it prophylactically, when people are well, you're giving them a drug which has a small risk of causing nasty side effects. It's a disaster. They're putting hundreds of thousands, if not millions of people onto this drug with no evidence. And by the way, it pushed the price up tenfold. The price of chloroquine would jump by a factor of 10. It was awful. This is not the way to do science. Thank you, Mr. Trump.
We are fast running out of time. We have a couple of questions. My favourite question of the evening, it's made me chuckle, is from Cecil Tates. Forgive me, I don't know you, Cecil. He's written, why not lift lockdown restrictions on under 50s so that the economy can restart, as over 50s make up 99% of victims? He's then gone on to clarify, PS, I'm quite a bit over 50. So between the two of you, Peter and Laurence, and then we'll do a final question. We'll go to Harvey Bratt in a second. So I'll let you two answer that one first. Getting the economy going by shielding the over 50s.
Peter, you want to
go? I think it's an issue that whether it would really work and whether you would just simply see a huge number of over 50s dying from the epidemic. I think that the way to get the economy going is to do far more testing. I think if you allow younger people out, they will be spreading the virus. One of the problems with mumps, for instance, is that it can be spread through younger people, and then older people die from it and get severely ill from it. And so in the past, now we have vaccines for it. In the past, we relied on the fact that so many people got it when they were young that it wasn't a problem. But not all viruses, a lot of viruses are much more severe if you get them older, but the whole transmission of it is that it spreads around. And to maintain a small proportion of the population in lockdown and not the majority, I think, becomes very difficult. You've got to think what's going to be happening with schools, who's doing the teaching, what are you doing about doctors in hospital, those who are over 50. And I think it would be very difficult. I'm not a sociologist, so I don't know exactly how it would work, but I doubt if that would be a good way of doing it. And from a Jewish perspective, it seems to be somewhat of a selfish attitude to say that we don't care about our elderly. But I don't know what Laurence or
I would just simply say, just think about how difficult it is to get the public messaging right. Stay home. What was it? Stay home, something, save lives. I remember 2 out of 3.
Protect the NHS.
That was it. You just see how difficult it is to even remember a simple message, okay? Imagine if the message was, if you're 49, you can go shopping. But if you're 51, you have to stay at home. It won't work. And that's part of the reason that this sort of messaging can't be done, quite apart from what Peter has said.
Thank you. We're going to go to Harvey Bratt. Harvey, you are live and loud.
Thanks, Stephen, and thank you, Laurence and Peter. Obviously, we've been warned against comparing one country with another. However, we've seen that some countries have decided to come out of lockdown at a much earlier stage and a much more rapid rate than this country. Israel is obviously among them. And I just wonder from an epidemiological point of view, whether that runs any greater risk of a second wave or a worse second wave than if you were to come out more slowly from lockdown.
You can get the proper epidemiologist view in a second, but let me just tell you as a doctor, I have no idea. And what I do know is that previous pandemics have had different trajectories. Sometimes you get one spike and then it sort of poppers along and then sort of disappears into the general population. Sometimes you get one spike and then a year later you get a much bigger spike. I don't think anybody knows, but Peter is the expert. Peter.
Well, so I don't normally do infectious disease epidemiology. I wouldn't really call myself an expert. I think two things. One is, one of the things that happened in Israel is that they dealt with the lockdown much more seriously than us. So people who were meant to be quarantining or isolating had visits from the police twice a day to make sure that they were staying at home. They also did contact tracing via your telephone without asking you whether you wanted that or not. And so people started getting messages to say that you were within a few meters of someone who's now tested positive, you must get yourself tested. So they took control of the epidemic in a way that we didn't do in this country, and you can discuss whether you think you would like it if we did it that way. But I think it's probably fairly safe with what they're doing now. I think if we were to completely end the lockdown now, we would definitely have a second wave within a month. The numbers have become very low, but they haven't become low enough. I just heard that in one major hospital, 1.5% of all cancer patients coming for treatment who they were testing had coronavirus without knowing about it. If it's that common, and you stop social distancing and these moves completely, it will be completely rampant again, and potentially worse than it was last time round. Although, yeah, who knows? It depends how quickly we go back into a lockdown. So, it is a very difficult thing. As Laurence said, I think the messaging is critical, and need to work with behavioural scientists to understand what to do to get people to reduce the extent to which the virus is spread, but trying to allow the economy to come back to normal and to flourish, because we can't go on like this forever.
We are quickly running out of time. I wanted to make sure I gave our speakers one final kind of 30-second payoff, and I'm going to throw to Laurence, who is seemingly the only person on the planet who is jet setting across the planet over the course of an hour. So I'll let you some closing remarks from Laurence, and then we'll go to Peter.
My question is, where am I now? Put the answer in the chat. I don't think you'll guess it, but it is one of the countries in the Crown Coronation trial. I suppose my message really is, although we've been talking sort of at a theoretical level, the public health messages are absolutely crucial. Social distancing, staying at home, staying alert. I can't remember the rest of it. You know where it is. But those things are really important because we do need to try and keep on top of this. Otherwise, it's likely to get out of control again. And if it gets out of control again, the NHS could really be overwhelmed. We only avoided it by the skin of our teeth last time around.
And Peter?
The two things, that slide that I was sharing, that was a picture of one human cell infected with coronavirus. The yellow dots, which were coloured, so it's not the actual colour, it's from an electron micrograph photo of it. Each yellow dot was a virus. So you can see just how small the viruses are. I think the important thing to add to what Laurence said, that you need to think there's both what you do to reduce your own risk, and you may not care about your risk because you might think, oh, I've had it already, it's not important. And then there's also what you need to do to reduce the risk to society of there being a second wave and another 50,000 deaths from coronavirus in this country. And it is possible that you might be able to spread it even if you don't catch it yourself. And so I think keeping social distancing as is being recommended is very important, not just for yourself, but for everyone else around you.
Thank you. I'm loath to end on a negative note, despite the fact that Laurence is by the beach in Ghana, apparently. But I'm going to use my chair's privilege to ask the last question. It's a one-word answer to both of you. Thanks, that's better. So Laurence, now safely back on the Thames side. What's the next, same question to both of you. When will we next be having Kiddush in our shuls? What's the next Chag, the closest Chag that we'll be having Kiddush in our own shuls?
Gosh, Rosh Hashanah next year.
Peter?
Earlier than that, Kiddush will be different. We'll be keeping some social distancing, but I hope we'd be back. When you say next year, do you mean next Jewish year or next calendar year?
I mean 18 months' time.
Yeah, I think we might be able to have the Chazan making Kiddush in the evening on Rosh Hashanah this year.
I agree. Okay, well, we agree as always.
Let's all go for that.
The interesting thing is whether they'll allow shofar blowing on Rosh
true.
Hashanah this year.
I'm trying to end on a positive. You just keep dragging me down. So I just want to say thank you so much. I'm going to do something which I've never done on a Zoom, but I'm going to simultaneously unmute you all so you can all give our speakers an enormous round of applause. Apart from we're thanking them not only for giving of their time this evening and clearly the preparation they've put into it, but I think the fact that they're on the front line makes all of us a lot safer in what they do. So if you'll join me in now, all unmuted, you can give them a big clap. Seize power back and mute you all again, just to let you know about a few the upcoming things. So as I said at the top, this is the first of a three-part series, all taking place on Monday nights, all about the race to beat COVID-19. The next week, also together with Riley Close, Ale Sion and Magen Avot, we are talking about dealing with those infected and affected by the virus with Dr. Alan Stauer. It may be his wife, I don't know, whoever turns up on the Zoom call first, and Judy Baumfreund. Thank you everyone for giving of your time. You are contributing by staying home and doing this like this, bringing our communities together, and it's lovely to see everyone's faces. Everyone look after yourselves, keep well, and have a great week. Thank you again to everyone who's organised, participated, and joined us this evening. Thank you.